So we're just taking a general look at the tissues surrounding the iliac crest, right? So to identify the iliac crest, we use our concept of palpation. So first we use visual, right? I can see that the patient's leg is here, I can see that the patient's abdomen is here, I can see a dip, right? As the patient dips, regardless of the size or shape of the patient, they will usually dip towards the pelvis from the abdomen. I can see an area right in here where I believe the ilium should be. So I can use a broad hand, broadly contact in. What pushes back as hard versus soft, right there. So under this finger I have the bone. Now I have the iliac crest. I've identified it, and as I wrap my hand around, I can identify the ASIS, right? So I can move through that tissue confidently to identify the ASIS should I need to. But if we're looking at, say, the innominates, right? A major osteopathic fetish, and fetish for many other manual therapeutics, that the motion of the innominate, or the pelvis in relation to the sacrum, or the pelvis, generally speaking, anterior and posterior tilts. What we want to consider is the tissues that are probably going to be creating that motion. And the tissues that don't get spoken about very often would be the erector mass in relation to the pelvis, the obliques, internal and external, and the rectus abdominis. Now with a hold like this, good old, what we can call a yoke hold or a pistol grip, depending on who you are, what we can do is effectively push in and assess those tissues, right? So we can assess the yield as a short lever motion test. We can assess the yield, and we can compare side to side. So I can go over to the other side. We can create relational motion. So I can, if I find an area of this tissue that is high tone, I can create relational motion. So I can move off the patient's thigh, right? I can lean in with my forearm, I can push with my hand, whatever I want to do to create motion of the pelvis in relation to my steady hand on the soft tissues. Now the reason we want to talk about the obliques, the rectus abdominis, the erector mass, is because they're very large muscles that create quite a bit of motion, and they attach to the pelvis. A lot of people will speak about the hamstrings, which definitely have influence on the pelvis, but again, the ilium will move about 2 to 4 degrees in relation to the sacrum if the sacrum's steady. Well, the sacrum will move about 2 to 4 degrees maximum in relation to a steady pelvis or a steady innominate. So what we want to consider is if there happens to be a motion dysfunction or subjective discomfort around the pelvis, we want to consider the big tissues. So again, the rectus abdominis, internal and external obliques, and the erector mass. Now from here, I can effectively create that yoke around, but I tend to run out of the opportunity to contact the erector mass, and then I can flip my hand. So I just flip the yoke over. Now here the problem is I'm working in the dark. I can use a medium lever, right? So you see how I just kind of lean into the patient's pelvis, and I can keep my hand still if I've hooked onto the erector mass and lean in. I can have a patient bend their knee, and I can, again, test through these tissues to see what I can do to loosen them up. So I can move the leg in relation to the pelvis in relation to my hand that has essentially fixated on the soft tissue. So the soft tissues are then, the bones are moving in relation to the still, relatively still soft tissues. Okay. One of the things that I can do if I've identified, right, so we can test either side, I could move over to the other side, test which side is giving me more feedback, more palpatory and visual feedback as having higher tone or lack of motion. I can put that side up, right, so I can have the patient in lateral so that I can expose it. So concept of patient positioning, anatomy should be exposed, free to move in a plane required, they're preferably visible. So I'm going to have you lay with this side up, just for the purposes of demonstration. Here. Here. Come back towards me a little bit more. Okay. And we control the patient as they come back. We give them haptic feedback. We give them palpatory feedback so that they know not to move too far. That's why you'll see me like this. I've controlled my patient so that they can't go back any farther. Now here, I can really come around that entire iliac crest. So from the perspective of multi-point discrimination, I can start to identify as a short lever motion test where I'm running into a few more problems. Now, we should recognize that as we get slightly more posterior along this iliac crest, So as we push into the obliques, we should expect some yield, a reasonable amount of yield on most people. There's multiple possible reasons. One, it's just softer. Two, as they lay on their side, there's the possibility, depending on the dimensions of the patient, that they will essentially sag towards the table. How much that will happen is questionable. You can bolster them up with a pillow under the side. That doesn't work all the time because the pillow will also deform, so it doesn't do as much as we think it's going to do to essentially neutralize this. Whether it's neutral or not doesn't matter as much. We're really just trying to check through these tissues. So I can get around here. Again, it should be soft. As we get further posterior, the erector mass should generally feel firmer, especially the lateral border of the erector mass as we push in. It will pop into your hand generally quite firm, at least from clinical experience. How true that is universally, I don't know, but I know in my clinical experience, that's what happens, right? So I can do something like this. I can take a standing position. I can work through here. I can switch my yoke. When my thumb comes down through the erector mass, I can actually pull the erector mass away. So I can get good multi-point discrimination. I can do something like this, right? Essentially make moose antlers or whatever the heck you think this looks like. Come around, right? I can cross over and I can compare these tissues to one another. And then from there, I can create treatment. So if I found, for whatever reason, soft tissue restriction in a comparative sense here, put my yoke on, and I can pull the pelvis around. I can push the tissue up, right? I can pull the tissue up. I can keep my hand still, so I can move the soft tissue in relation to the bones it attaches to. I can hold the soft tissue, move the pelvis in relation, or I can reach over to the thigh, use my abdomen in contact with the patient's pelvis, and I can start to relation move. So I have to make sure that this hand stays as still as possible so that I hold this soft tissue steady, and then I can move the bones in relation to that soft tissue, right? So we're using the concepts of patient positioning, the concepts of multisensory integration, because I can see all of this, right? Now, as far as multisensory integration is concerned, if I really think I'm getting a good release of the tissue here, one of the reasons is because I've leaned into the patient too much. I rolled the patient, my hand has moved, this hand has moved, right? So something is happening that I don't think is happening, or I think something's happening that's not actually happening. And then I can start to pay attention to all this. So if I see the patient rocking, I know I've gone too far. So patient positioning, multisensory integration, and relational motion are all essentially shown here. And it's because we want to be able to assess along this iliac crest, again, if there is some form of motion dysfunction that we've identified in varying ways, however we've tested that, or the patient has discomfort in and around the pelvis or the iliac crest. We can assess broadly short lever motion test through all these soft tissues, right? It's nice in varying ways as we've already discussed.